Good morning and afternoon, everyone. Thanks for joining us again for another great session at the Achieve 2020 Health Current Summit. I get the opportunity and honored to introduce a number of our colleagues from around the country to talk about HIE public health responses to COVID-19. So before I hand it off to the panelists, I'm going to do a brief introduction for folks on the phone. We've got, starting off, Dr. Craig Beam. He's the Executive Director of the Chesapeake Regional Information System for Our Patients, or CRISP, followed by Jennifer Baumgartner, who's a research scientist at the New York City Department of Health and Mental Hygiene. And then we're going to wrap it up with Todd Ragau, who's the President and CEO of Helpix in New York. So guys and ladies, thank you so much for joining us today, and really looking forward to your panel. So Craig, I'm going to hand it off to you first.
That sounds great. Thank you so much, Morgan. Thank you for having me. Let's go to the next slide and dive right in. So just very briefly, CRISP is a regional health information exchange, very similar to what you all have down in the Southwest. We cover Maryland, West Virginia, and the District of Columbia, but I'm going to speak primarily for Maryland today. And much like our counterparts, really all we're about is cooperation and collaboration and figuring out how we can leverage health information technology to make our lives better for the providers and patients we serve. So now we're going to go into the use cases for CRISP. Next slide, please. We have really 5 services that we like to consider the scope of the HIE. And you see them on the left side. It's kind of classic HIE, where we will provide data at the point of care, normally labs, health records, care alerts, different information. We provide encounter notifications to support care coordination. And then Maryland's a little bit different. We have a really unique payment system. So we do a lot with claims-based reporting for population health purposes. We do a number of different public health support activities, partially for Maryland for our unique infrastructure, but then also for West Virginia and DC. And then program administration is kind of this unique role we play, almost as the referee between our hospital system as they negotiate rates and our rate commission as they decide whether or not to accept those negotiations. In terms of COVID, you can really see here, the first 4 services were really directly translatable to being reused to support the public health response. Of course, the point of care and care coordination was really all about making it known whether or not a patient was positive or negative. We ended up doing a lot with reporting. And then I'm really proud to say the state looked to us, much again as your HIE is, as a trusted partner to really become a technology integrator on behalf of the state. We were able to move so much faster as an independent nonprofit than the state could in many cases. So I'm going to take us through just a couple of use cases to maybe elaborate on those 3 boxes there. So the first, right when the pandemic started, we already had a number of lab connections, but the state of Maryland provided us with their electronic lab reporting feed, essentially a split before it got to the Department of Health. And that allowed us to very quickly analyze and push out results to care teams and providers at the point of care. We also received daily confirmed case files, so we had exactly the same work that the epidemiologists were looking at. And we could use those files to do things like you heard in the last presentation, protect our first responders if they came in contact with an active patient. We did a little bit of de-identified research work. And then more recently, and maybe most excitingly, we are essentially kicking off the contact tracing process for Maryland. And so we take those feeds that we get in real time, and every half hour we push new cases to our COVID link system, which is a Salesforce platform that MDH, the Department of Health, built. And we're initiating the phone calls to all the residents across Maryland who have confirmed cases. And now we're helping with things like antigen tests and the different kinds of point of care test results that are also being pushed into that process. So next, we've been doing, of course, provider and patient communication. You'll see on the right side of the screen here, that is our in-context FHIR app. So if you're in an Epic system, for example, or now Cerner and Athena, this little box will pop up right in your EHR, and it has traditional health information exchange patient data, but it also has infectious control alerts, which is where you'd find COVID, we pushed that through our traditional portal as well. And something that I'm really pleased with our team. Early on, it was, as everyone I'm sure was in the same boat, it was all hands on deck. And so we asked our customer care team and our outreach team to man the phones. And when the state had nowhere else to send patients to support scheduling and different workflows, we ended up doing a lot of patient phone calls, which again was unique for us, but we were just happy to be infrastructure for the state for these purposes. The next use case is going to pivot into reporting. So now we, oh, I'm sorry, we're doing test site support. After this, we'll do reporting. I mentioned that we were a technology integrator for the state. One of the kind of really early creative use cases we were asked to solve was that the state wanted to stand up testing sites, and these sites were going to be distributed across the state, and physicians would have to be allowed to order a test, and a patient would then go to any test site. And so it was not within a healthcare system, it was not within a single network, it was kind of a free-for-all. So the HIE, because we are the prescription drug program monitoring program kind of endpoint, already had the vast majority of physicians with access to a portal. And we reused a referrals portal we created for social determinants of health to allow physicians to place lab orders. And once we did the front end of the workflow, we had to then text and email patients if they scheduled to confirm the dates and kind of go to a calendar app. And then we actually had to stand up the software for the drive-through testing sites so that the employees could check in and check out patients to confirm and kind of manage test kit volume and staffing volumes and report out their throughput. So we're doing less of this volume now, thankfully, as supplies have increased and the rest of the healthcare community has really gotten on board. But we're still operating about 10 sites throughout the state and doing nearly 5,000 tests per week. Next is reporting. So we already, as I mentioned, because of the state's unique payment model, had a pretty robust reporting infrastructure with which we use a special hospital adjudicated claims set and then also Medicare claims data. It's all built in Tableau, and we have a couple of really good partners that support us. Well, we were asked to do more reporting, essentially serving as a single hub so that as different data sets became available, people weren't asking providers or the health department for this data over and over again. We could be a single source for multiple users. And so one of the use cases here is lab tests. We took that electronic lab reporting feed, put it into the reports, and we could very quickly show tests per day, result percentages, population adjusted test rates to make sure there are no significant disparity issues, and just other kind of really important information. And it's updated every morning around 6 a.m. Another use case, which was a little more advanced for us on the reporting side, no, I'm sorry, here's a screenshot of the days to result. Let's go one more. And we partnered with our emergency response people, the MIMS, as we call them, the Maryland Institute for Emergency Management Services Systems. And they already had hospitals submitting facility reports to them to then provide things like occupancy percentages to check acute care and ICU capacity and support the surge response planning work. Well, we ended up being the reporting portal for MIMS and then created these reports that are actually the source of truth for the state on our public website. And they're helping the surge team as they model the different waves that we may go through and make sure we have appropriate capacity in the hospitals or in the convention center that we retrofitted earlier in the year. We are doing the same thing for skilled nursing facilities, where all 227 sites are mandated to submit to CRISP every day. And again, it's a really, really effective way to not only support the state as they support outbreaks or kind of potential hotspots, but it's actually helpful because hospitals, skilled nursing facilities, physicians can log into the exact same portal that the epidemiologists are using and that other public health stakeholders are using and understand what's going on in their region. They don't have to ask health officers. They don't have to ask the state for reports. They can look in the normal portal that they would otherwise be comfortable using. And next, we kind of right before COVID-19, we had plans to build out kind of an Azure native big data resource to link different parts of the CRISP infrastructure to help drive insights for things like query volume across sites and PDMP compliance reporting. Well, we pivoted that and instead put in a bunch of the data related to COVID and related to patients. And it's allowed us to create demographic trends, to look at race, ethnicity-based case volumes, and really do some creative reporting that's always changing. It's on the fly, and it allows the state again to be very nimble. So that, for example, recently we've been asked to try and match the dashboards that the federal task forces are providing to the state, so that our governor is not surprised when something turns from green to yellow or yellow to red. And so that's the current task at hand. And then finally, just looking forward a little bit, you know, we are, if you can find a silver lining in these kinds of things, first, as I said a couple of times, we're incredibly proud that CRISP has been able to be reused as this essential infrastructure. It's exactly why we're here. As a nonprofit, as a member of the community, we've been volunteering across the board because we want people to extract the value out of a 10-year-old HIE. We also are trying to consider, how do we look ahead to use these new skills, to use these new services and relationships to provide even more value going forward. One idea, and I'm proud to say it went live today, was to work with our universities to execute data sharing agreements, which was a fun process to get around FERPA through the emergency use exemptions. And we're now labeling students from 2 universities in the state so that when they go to contact tracers, they can immediately work with the health officers to execute local task force kind of plans, rather than putting them in the broader pool of kind of potential contact tracing candidates. We're also then using HIPAA authorizations to provide data back to the universities, so they're not forced to kind of track people down or rely on necessarily just self-reporting, so long as students give permission. And I think this is going to open the door to a lot of those kinds of use cases, as long as we're very thoughtful, very obviously protective over the data, and execute as we have been. So I think I'll turn it over to the next presenter, and certainly stick around. I'm looking forward to discussion.
Hi, my name is Jennifer, and I'm from the New York City Department of Health. And I'm really excited today to talk about how the HIEs assisted the New York City Department of Health during our COVID response. And so next slide. So yeah, just a little background on COVID in New York City. Our surveillance began in January of 2020. And like Maryland, we primarily get most of our data from our electronic laboratory reporting system. In New York City and New York State, this is a pretty mature system. We've had ELR for over 15 years, but it's limited to demographics, ordering, provider, and facility information, and lab testing results. And so typically we have to do investigations for all of our diseases to get that like supplemental information that we really need, like hospitalization, with like ICU status, and just any other additional information. You can see from, like our epi curve over here that was sustainable for about a week into our COVID response. And the volume of cases became so high that we were unable to investigate every case. And so, like these data are about a month old, and now we're almost to 250,000 total cases. So we knew we needed like another way to get this critical information. Next slide. One of the things that we started doing is we started thinking like, okay, we'll reach out to the hospitals and they'll just provide us like, a line list report. And in New York City, we have over 50 hospitals, and that also lasted, about a week before the hospitals became overwhelmed with health department requests. And also our investigators became overwhelmed. And so our next step was to reach out to the HIEs in New York City, which there are 2, to try to find an additional way to get this critical information, such as I mentioned before, like the hospitalization, admit and discharge state, ICU, and mechanical ventilation, important underlying health conditions, the patient disposition, and race and ethnicity. And then I also just wanted to mention, outside of COVID and case investigations, like we really use the HIEs a lot to find additional locating information, like additional patient phone numbers. And so the HIEs have also were really critical in filling in those holes. And so around, the end of March or 1st of April, we started receiving these reports from the HIEs, which included all this supplemental critical information. And you can see from our hospitalization chart, most all of these data here were reported from the HIEs, and this is on our public website. This chart is from our public website. So next slide. Another thing that we really relied on the HIEs to do was to fill in supplemental information. Our race and ethnicity information reported from electronic lab reporting is very low. It's less than like 15%. And so without the HIEs and also our vital registry matches, we wouldn't have been able to find these like really discouraging disparities that we found early on in the outbreak. And then, so with these data, we were able to kind of like find neighborhoods, find populations that needed additional resources, that had low testing rates, and, kind of like provide more resources, which was a great public health action that we're not sure we would have been able to do without getting these really important supplemental data. Next slide. And then just, going forward, working with the HIEs was very essential for our public health response, but it also was like such an important lesson learned for us that we had never really received these type of data, like direct reports from HIEs, and integrating them into our system, like in the middle of a pandemic, it was not ideal. And so it's kind of like a lesson learned that like, there's so much data there, and there's so much more we want to do with this data, but just preparing in the future to be a little bit more ahead of the game. And so we definitely support like HIEs getting more support on the national, state, and local level to support these efforts. We wouldn't have been able to report out on a lot of indicators without the support from the HIEs. But we need to work with the HIEs to improve bidirectional data flow. Like I said, it was a huge task for us to get these data and processed and matched to our own surveillance system, in real time in the middle of especially our peak one, which was in March and April. Help improve the data quality and completeness. And then also, this is important too, we found like just receiving these data directly from the HIEs was really appreciated from the hospitals who we were calling to get all this information. And so the burden that it took off of, routine standard reporting that's required by hospitals was appreciated by our own case investigators, and also definitely the hospitals. And then just to wrap up, we just wanted to thank the HIEs, the New York City HIEs, for being so willing to work with us. They were so accommodating to all of our requests. The teams have been great to work with, and we definitely want to support future projects and like Craig had mentioned, like additional use cases, and like figure out like more ways that they provide value to the health department and to New York City as a whole. So thank you very much.
Great. Thank you, Jennifer and Craig. So Todd's going to bat cleanup here. So Todd Ragau, from the president and CEO from Helpix in New York, take it away. Todd, you're on mute.
Yeah, technology got me. All right. Well, thank you very much for the smooth transition on your end. Hi, my name is Todd Raghu. I'm the president and CEO of Helpix. And we do cover New York City and Long Island. We do have a lot of facilities connected to us in the Bronx, but there is another HIE in the Bronx, which we work very well with to support many of these efforts that Jennifer just went over. So let's go to the next slide here. So we make up a broad connection. There are several HIEs in the top right of the screen here that you can see throughout the northern part of the state of New York. We're connected to Chic and the eHealth Exchange, as well as a nationwide network. And then in the lower left, private HIEs. So some of the larger IDN hospital systems, they do act as aggregators to us as well, which is greatly appreciated in their diversity of ambulatory and other types of facilities that they collect that data and send it to Helpix, and we make good use of it. Now let's go to the next slide here. So just to give you an indication of the size of data that we deal with, this gives you a few key indicators here. So we bring in 250 million messages every month. We like to think we compete with a stock exchange, but we really don't. But anyway, it's a lot of data coming in. We also push out a lot of data. So we push out over 7 million messages directly right into the workflow of clinicians. So right into those electronic health record systems that they use. It could be ECW, it could be Epic or Cerner, et cetera. And we have 31 EHRs that we've really gone through this tight integration with. So that's moving those continuity of care documents over, or think of a CCDA formatted document into their workflow. And in return, they do the same on our end. We also try to leverage our alerts out directly into the clinician workflow through these EHRs. And then the clinical alerts, which is the lower right, about 9 million of these go out on a monthly basis. During the really hard months for COVID for New York City, which was March, April into May, we had pushed out well over 8 million real-time alerts just based off from lab testing. And we would send out both positive and negative results to care managers and clinicians across the community on residents of New York who were being tested at that time. So a lot of data coming and going. And let's go to the next slide here. And here's one of the use cases I'll quickly highlight. You may have heard about this a while back in the news, but the Javits Center was probably the biggest or the largest field hospital, which was stood up in New York. It was leveraged for COVID patients. It started to be actually non-COVID patients, and then they ended up transferring COVID patients into it later on. But they didn't have an electronic medical record system to access patient records with. So we deployed Helpix's clinical portal, and we had decent success on having people use our front end to really understand the history of these patients as they were being treated. If you go to the next slide. And there were several other use cases, and some of these are going to be similar to other HIEs, I hope, across the country. But we had, in New York City, you could call the 311 number, and we would also, through the clinical data, basically the encounter data of patients, we would help families locate loved ones. And there were many instances where they were following up with one of their family members, and they may live outside New York, but their family member was in New York, and found them to be admitted into a hospital. So we had many really positive scenarios of having the HIE kind of be leveraged in this fashion to bring families together. You see the second use case right below that, which is some of the data which was gathered through the HIEs in New York State was used to support some of the research done by the State Department of Health. And then I already mentioned the alerts, how they were used heavily throughout our community, really in real time to keep people informed of the situation kind of across the city and collectively across the state of New York. The next slide. We'll go into the next slide here. All right. And then I wanted to tell you about some very active and more recent activities which we've been working closely to support. One is through the City Department of Health and Mental Hygiene, which Jennifer works for, an extension of them working with H&H, which is Health and Hospitals, on contact tracing. And this is something we've been supporting for, I don't know, well over a month now, probably more like 2 months. And what we do is we have a specific role to really help them. As Jennifer alluded to, a lot of the data which they collect today, they don't get strong or filled out demographics. And what we're doing in this case is we're getting a list of residents of New York who they want to reach out to, and we're supplying them with cell phone numbers, addresses, etc., to help them really try to get hold of these people and let them know that they may have been in a close proximity to someone who has COVID-19. So that's an ongoing effort, and we've heard some really positive things. The match rate, interestingly enough, from a Helpix standpoint, has been above 95%. So we're really getting a good match rate on the resident, which is exciting to us because when you're managing well over 20 million lives, and that's more than reside in New York City alone, it gets challenging to make sure your demographic matches are in good shape. But we've had really high success on this front, which is exciting. And then the second item on this slide right below is something we've just started as the flu season, or as we enter the flu season. We and the other HIEs throughout the state are all involved in an effort to do syndromic surveillance and to really track the spread of the flu. Obviously, there's a positive or correlation here that could happen with people catching the flu, also COVID-19. They're similar in how they spread. So it may not be diagnosed right away that someone has COVID-19 until they have that test. So the city in particular, and also the state's very interested in tracking this across New York State at the moment. So our role in this is really to provide them with that testing information. So we're looking for those key tests that narrowed down on these two conditions, the COVID-19 as well as the seasonal influenza, as well as providing them with historical information on the patients who are impacted. So they do want to understand not only race, ethnicity, and gender, but they want to get into the clinical backgrounds of these patients, and so they can hopefully effectively treat them and know what's going on in the local environment. If you've been following the news at all, and I don't know if you have heard specifics about New York, we have had some hot spots which have come up in the Brooklyn area. And I'm not the expert exactly what is a hot spot or not, but we've been working with our local hospitals to help get a handle on this as well. So aside from working with the City Department of Health and Mental Hygiene and the State Department of Health, we've also partnered with several individual hospitals to help them in a hotspot situation to really help them understand. Again, it's the traditional role of an HIE, pulling that historical data for those patients and making that available to them, but also helping them understand the spread so they can adjust their services and their staffing to be prepared for the situation getting worse. So we do play an active role in that. And then if we can go to the next few slides, I just wanted to show you and talk a little bit about, you can click it one more time here. Thank you. Just about our predictive analytics and what we're doing here. We're starting to leverage this more and more in targeting those high-risk patients. We're trying to get ahead of the curve a little bit, not just be on the responsive side. So as you can see, what goes into our predictive analytics is all that clinical data that comes to an HIE from all of our data providers, labs, hospital systems, etc. And then we also supplement that with additional social characteristics or social determinants of health. We pull in over 30 different social determinants of health data, and we do this from both census and CDC data. So it's either by census tract or by zip code. And that helps augment and really supplement in a positive way all that real-time clinical data which we're receiving. And then on the right-hand side of the slide here, you can see we've got a good listing of our risk models. And again, this helps rank the population and individuals in terms of what their risk is of coming down with COPD, coming down with diabetes. We have a suicide risk as well, and opioid abuse. So we have these risks, and then based off from their risk score, we can tell you how they compare to the average across the United States. And hopefully they can use our list to do that outreach, which is really critical to be proactive in healthcare and reach out to these patients and hopefully bring them in the ambulatory setting or get them the help that they need through CBOs and other types of organizations. Let's go to the next slide here. This just is a visual of several of these indicators across the bottom of the slide. And each of these bars really represents a group of individuals. And if this was a live demo, you could hover over those bars and you could see how many patients fell into each of these classifications from 0 to 100. Now 100 means that that patient already has that condition, so they may already be diabetic as a good example. So as you kind of move up, in this case move down, but towards that 100%, you have a higher risk. And then what's really nice is if you get drilled down to the individual person, or if you drill down to that cohort of patients, you can see in the middle of the screen, it will adjust in real time, and it will show you the other comorbidities that those patients may have in that group that you kind of select. So we have this kind of slice and dice functionality available to our predictive risk modeling. And we work with many of our organizations in New York to really try to take advantage of this. And I think it's really important, especially now, to try to get ahead of some of these curves. And if you go to the next slide, one other step we've taken is we brought in some of these risk scores. You can see in the kind of red and yellow orange color here in the middle. We've brought them right into our clinical portal. So as you're looking, if you were to look up Todd Ragu in our clinical portal at Helpix, you would see, this is all test information, obviously, but you would see full encounter information, diagnosis, allergies, medications, etc. But you would right on the top, you would see, what is my risk? And what we're trying to do is we're trying to make this all very actionable in terms of giving that clinician the ability to know Todd Ragu is at risk right now. Is someone from a care manager standpoint working with him? And then let's go to the last slide here, which is just a visual on COVID-19. So we've been playing a lot with how to make dashboards more meaningful in our space of New York City, Long Island. And there's a lot of data packed on here, but I just wanted to kind of show you some of the stuff that we've been doing in New York to try to, again, leverage this data and make it more actionable. So I think that's it. Thank you so much.
Thank you so much. So I am getting support from folks behind the scene here to try to pull questions that are coming up through the live session. So I'll get to those as they come across. But I think trying to pull on the thread of Craig's earlier comment about finding the silver lining. I think, you know, we all would love some silver lining as we can find them. Can you guys just take a second and tell me what is one of the most encouraging, or one of the things that is really an uplifting lesson learned over the last 6 months in response to COVID? And I'll just work in order of presentation. So Craig, you want to take first shot at that?
Sure. So like two things come to mind. The first, I don't know if you all get those if you use like Microsoft Office, but I get the Microsoft Insights through my email, and it gives me like the number of people I've collaborated with, and it's like every week it's like 60 new people, 80 new people, and I'm just struck by how much, not just CRISP obviously, but kind of HIEs, the hospitals, the public health agencies have all like really come together to mobilize. So it's exciting to build the new relationships and have these new partnerships. I also have been really pleased to see, I think we've all in the HIE community built infrastructure that had very specific purposes, but that we hoped would have advanced purposes. And much of what we've done has been extremely applicable and reusable as we get asked to do more and more public health related work. So I'm glad that we can provide that value, and that the investments we've made have turned out to be good ones.
I couldn't agree with you more, Craig. Jennifer, how about from a public health perspective? What silver linings have you been able to find or identify over the last 6 months or so?
Yeah, I mean, I would agree with Craig from the public health perspective. We've always used the New York City HIEs, but more from like the, like looking things at one by one in the portals. And they've been, like really so helpful to all of our case investigations. And we've always had kind of like bigger bi-directional data sharing projects on our list of things to do, but we haven't ever, like actually got to them. And I feel like COVID really provided the, like, I don't know if we'll ever have a better use case than COVID, but we've been able to set up so much, like data exchange and understanding the data and figuring out how we send it to like Helpix, for example, how we get data back from Helpix, that I really think is going to help so many of our future projects. Yeah, like post-COVID. So definitely a silver lining there.
Perfect. And Todd, before you respond, I would just encourage people to type your questions in chat if you've got them, and we'll get them over here in our last 5 minutes. But Todd, go ahead.
Yeah, I mean, COVID's given us a silver lining in the sense that all those people have been screaming about data quality for all these years. I mean, they're absolutely right. There's no doubt about that. We deal with so much data. We've had an issue of trying to balance between new data sources into the HIE versus deep data quality. So we had to react quickly, and there's still more work in front of us on dealing with some of our data quality issues. And this goes all the way back to the senders of the data, right? It's not just something that we control just within the HIE. It really goes back to how the data is entered and what format they use and how then it comes over to us. So data quality is just one of those silver linings that COVID has allowed us to spend this time to actually do a deep dive.
That's excellent. So I know that we only have about 2 minutes left, but I do have a burning question that I'm really curious about. Each of you talked a little bit about the connection to patients as a result of this, and historically that's not really been where HIEs have lived. So where do you feel like all of these activities are going to take you in the future in terms of building those connections with the patients who we manage their clinical information for?
First, I guess to go in order, our board, every board meeting we have says we're the information system for patients. Where are the patients? And between that and the federal interoperability rules, we know we have to get there. The state has asked us to stand up a patient portal only for COVID results, which is hopefully going to go live before Thanksgiving. And it's going to be a really nice way to dip our toes in the water to see how knowledge-based authentication works, how we upgrade to other kind of NIST level 2 requirements, and really just try it out and see what we get. So that's at least an exciting experiment for us.
Yeah, and on the public health population level, just being able to fill in additional like data gaps with HIE data, I think really serves our public.
I think it's always been a goal of Helpix to make this data available, since we are an aggregator of clinical data, make it available to the residents of New York individually. We're working through I'll call it privacy concerns around that to make sure that, Todd Rago is Todd Rago, that Helpix isn't sending my data to someone who's pretending to be Todd Rago. So that's a, security privacy concern we're working through. But we're definitely in support of it. I do feel that the whole healthcare ecosystem is starting to make this pivot. And for those who want to be engaged in their healthcare more directly, this is fundamental that they have access to their data in an easier fashion, whether it's through an app on their smartphone or through some other means. But we do feel that the HIE can play a big role in that. So we're excited about that piece.
Well, thank you all so much for the work that you've done. Thank you for coming and sharing with us. We're all in this together, and I couldn't emphasize the importance of collaboration enough myself. So I know that we're standing between everyone and lunch, so I'm going to hand it off to Melissa to let us know what's coming next. So thank you guys so much and have a wonderful afternoon.